Welcome to Anesthetist 101. In Moorhead State's Veterinary Technology program, the day before surgery is spent doing prep work. As an anesthetist, this not only includes doing a pre-anesthetic exam on your patient, but also gathering all of the needed supplies that will be required in both the prep area and the OR. The first step on the day of surgery is to give the patient pre-anesthetic medications that will prepare their body for full induction of anesthesia. Once this has been done and the patient is in a relaxed state, you can begin the steps for placing an intravenous catheter. Depending on the size and disposition of your patient, the placement of an IV catheter may be done either on the exam table or on the floor, as seen with this larger patient. The successful placement and taping of an IV catheter is an important part of your grade as an anesthetist and should always be done to the best of your ability in a tidy and neat fashion. After placement and taping are complete and patency has been confirmed, the patient is typically moved to the table to continue with the anesthetic process. Before full induction of anesthesia, there are a couple of things that need to happen. The first of these being a last leak test of the anesthetic machine. This helps maintain safety and accuracy during the administration of anesthetic gases. While some patients may require full induction of anesthesia to allow for the prepping of the surgical site, others, such as this patient, will lay peacefully during prepping. Oftentimes, the surgical team will opt to prep the site at this point in time so as not to feel in the way during the full induction of anesthesia. While the surgical team is prepping, it's a perfect time to confirm the size of the ET tube and perform a leak check on the tube to make sure that proper inflation of the cuff will be maintained once the ET tube is placed into the patient's trachea. After the ET tube has been checked, it is recommended to add a light layer of sterile lube around the deflated cuff portion to allow for easier passage of the tube through the trachea. Be careful not to put lube in the Murphy's eye at the end of the tube, as this will obstruct breathing. Once everything is prepared and you have received the go-ahead from your teacher and fellow students on the surgical team, you may now induce full anesthesia. From this point on, either you or another member of your team will be responsible for taking the vitals of your patient every 5 minutes and recording them onto your anesthetist report. Once a patient reaches a level of anesthesia deemed appropriate by the teacher and yourself, you can now position the patient for endotracheal intubation. Placing an ET tube is a vital skill, and accuracy will always be double-checked by the teacher overseeing your surgical team. After placement is successful, promptly turn on the anesthetic machine and secure the tube to the patient's face. It is important to be as efficient as possible during this time to ensure that the patient is getting oxygen and isoflurane as soon as possible. The last step to complete in the prep room is to inflate the cuff at the end of the endotracheal tube to secure it in the trachea and avoid any fluids leaking around the tube and into the lungs. After all of these steps have been completed, it is time to move to the OR. During this transition time, it is important to recognize that the patient is fully disconnected from all anesthetic gases and any monitoring equipment. With this in mind, it is highly important to be as efficient as possible in getting the patient re-hooked up to anesthetic gases and connected to monitoring equipment. The first piece of monitoring equipment shown here are our EKG leads, or electrocardiogram. These will measure the patient's heart rate and graph the rhythm associated. The placement of the leads is typically remembered by the phrases, white on right and smoke over fire. Simply stated, this means that the white lead goes on the front right leg, the red lead goes on the back left leg, and the black lead goes on the front left leg. If there also happens to be a green lead, this would go on the back right leg. Shown next is the SpO2 monitor, which can be attached to any mucous membrane and measures oxygen saturation of the hemoglobin. Connected at the end of our ET tube is a capnograph, which will measure both inhaled and exhaled levels of carbon dioxide. To measure temperature in the OR, this gray tubing can either be placed in the rectum of the patient or alternatively down the esophagus, as is shown here. Shown next is the placement of a blood pressure cuff. When connected to the machine, the patient's diastolic, systolic, and mean blood pressure will display on the screen every couple of minutes. The final piece of equipment to attach to the patient is a fluid administration set. These are calculated to run a maintenance fluid rate while the patient is under anesthesia. While not required, an optional piece of monitoring equipment that can be used is the esophageal stethoscope. This provides a simple means of listening to the heart rate without having to reach underneath the patient's surgical drapes. To utilize the esophageal stethoscope, simply remove any tubing that is already down the esophagus, such as the temperature probe, and replace it with the tubing of the esophageal stethoscope. Because the ET tube is already placed within the trachea, passing the tubing down into the esophagus should be smooth and straightforward. Once successfully placed, utilize the earpieces on the end of the tubing the same way you would with any other stethoscope. For the remainder of the anesthetic session, the responsibility of the anesthetist is to closely and carefully monitor their patient's vitals and adjust the anesthetic protocol as necessary to account for any changes in patient reactivity, plane of anesthesia, level of pain, or simply the phase of surgery. A detailed record of patient vitals and anesthetic protocol is made during this time to be placed in the patient chart for record keeping. After the completion of surgery, it is the anesthetist's job to recover the patient. This includes monitoring the patient as they return to consciousness, removing the ET tube at the appropriate time, and administering any reversal medications on an as-needed basis. On the day following surgery, the anesthetist will also be required to visit the patient to assess the patient's status. At this time, the anesthetist will assess the patient for any lingering side effects of anesthesia, administer post-operative medications, and ensure the patient is on the way to a happy, healthy recovery.